So my name is Shar, and I'm going to talk about one of the more common conditions that I see in the hand, and that's called basilar thumb arthritis. So this will just be more of an overview on the condition, starting with the natural history of it, a little bit of anatomy overview, and then most importantly, the management of it. So a little bit of an introduction. So prevalence of arthritis in the basilar thumb is reported to be as high as about 15% in adults greater than 30 years old, and about as many as 1/3 of postmenopausal women are affected by this condition. Within the hand, the thumb actually provides about 40% of total function of the hand. So the pain involved in the thumb can be debilitating, as you can imagine. And overall, primary arthritis of the thumb is the most commonly encountered in the basilar thumb region, and I'll show that to you in just a second. So a little overview of anatomy. So in terms of terminology, there are actually multiple terms to describe the same condition. And for that reason, it can be somewhat confusing on what we're talking about. That includes basilar thumb arthritis, thumb carpal metacarpal arthritis, and trapezial metacarpal arthritis. Those are essentially describing the same condition. So if you look on the right side, this is a schematic of the bones in the wrist and hand region. So this is the area of interest. So this is the basilar thumb region. The reason that we have multiple terminologies describing that is because this bone is called the metacarpal, and then these little bones are called the carpal bones. And more specifically, this little bone over here is called a trapezium. So the basilar thumb region describes this region, and there are actually 3 separate joints. And then this whole region in general is called basilar thumb. So if you do an internet search on it, you might run into multiple terminologies that essentially describes one condition. The vast majority of the time, this joint is the culprit in terms of causing pain. So factors characterizing arthritis in the thumb include joint surface shape changes and ligament degeneration, which then lead to cartilage thinning and bone spur formation. So the thumb CMC joint, which is right over here, is actually a saddle-shaped joint. So if I were to take this area and zoom it in, this is the metacarpal, and this is the trapezium. So this bone is identical to this bone over here. And if you look at it, you can see how this is more of a saddle-shaped joint. One side is concave, and the other side is convex. So that unique shape allows more motion in the thumb compared to the other joints. So you have multiple planes of motion. I can go out, I can go back in, and I can also try to put my hand to the palm, which is a very important function in the hand. If you look at the bottom right, you can see how in one plane, this is a nice concave, convex area, and everything just conforms pretty nicely. You got kind of like the ball and socket equivalent of it. But because there's a lot of motion in that joint, if you were to turn it 90 degrees, all of a sudden, this doesn't conform nearly as well compared to the picture on the left. And because of that, there's increased pressure along the joint surfaces, and this is what causes the arthritis. So, however, the price of greater mobility is less stability, which can predispose to arthritis in that area. There are actually many ligaments that provide stability to the joint, and they degenerate over time, which contribute to the arthritic process. So if you look at it, the pictures on the bottom right, there are 2 ligaments in particular. One of them is called the volar beak ligament. So this is a picture of it looking at from the palm side of it. So if I were to take my palm and look at it, this is on the palm side of it. And then the other ligament is called the dorsal radial ligament. This is kind of on the side and slightly on the back side of it. But those 2 ligaments are the 2 most important ligaments in this area, even though there are many more ligaments that contribute to the stability. So weakening of these joints alter joint loading and causes dorsal radial, which means out and back, migration of the metacarpal base. So essentially, this bone starts shifting more outward and backwards at the level of the joint. So a little bit about clinical presentation. Primary symptom is pain. It usually starts as gradual, more activity-related pain, but then it can progress to become more severe and more constant. So activities that require strong grip, twist, pinch cause worsening sharp pain in setting of dull ache at rest oftentimes. For example, turning a doorknob. We don't think much of it, but there's actually a lot of force going from the thumb towards the index finger during that process. The other classic example is opening a jar. That actually puts a lot of pinch force along the thumb. But even less strenuous activities such as knitting or writing can also cause a similar type of pain. Other symptoms include swelling. You can get a deformity over the base of the thumb, difficulty in grabbing objects using the thumb, a term called opposition, which means basically bringing your thumb into the plane of the palm. And in rare cases, instability may be present, and this is usually in the more early stage of arthritis where the pain is not so much from the bones rubbing on bone, but it's more from the ligaments being weak and causes more motion in that area than a normal amount. And in a more severe case, you can get stiffness over time in addition to pain. So how do we diagnose it? I start by talking to the patient and then try to get a history of what are the things that causes the pain, how bad is it, how long has it been going on for, what have you tried so far, and then I examine the patient. So there's focal pain where pressure is applied over the joint, swelling at the base of the thumb. If you look at this picture in particular, this is the left and this is the right, you can kind of appreciate the asymmetry between the two. So the one on the right is more of a normal basilar thumb region, whereas the one on the left, you can see that more of a bump over here in the area that's swollen. And I'll go over why that happens in just a minute. There's an exam maneuver called the axial grind test, which just means that the examiner takes the thumb and actually push it down towards a joint and then basically try to move the thumb in a circular fashion. What that does is that it basically puts the bone against bone and then see if there's a lot of arthritis, then that can irritate that joint and cause pain. The other thing is traction shift test. This is when the metacarpal, which is over here, is actually, the examiner takes the metacarpal and actually move it back and forth around this joint and then put it back in place. And that can cause pain. And in setting of more advanced arthritis, there's actually decreased range of motion. So the patient may have difficulty being able to bring the thumb towards the base of the pinky, for example. Some other physical findings, there's a term called a Z deformity, and that's secondary to a few things that happen in sequence. So at the top is more of a clinical picture, and at the bottom is a schematic of the Z deformity. So if you imagine one limb here, second limb here, and here, that creates a lazy Z, hence the term Z deformity. Well, how does that happen? It actually starts at the base of the thumb, which is where the problem is at. I mentioned earlier that the ligaments degenerate over time, and that create more instability and motion at that joint. And what happens is that the metacarpal, which is over here, migrates more out and towards the back of the joint. And in the process, this metacarpal gets shifted in such a way that it is now located being closer to the thumb. And when that happens, the patient now has difficulty bringing the thumb out in order to grab the objects. And in order to compensate for that over time, the joint over here, which is the knuckle joint or the metacarpal phalangeal joint, it actually gets stretched over time in an attempt to try to open up the hand because the metacarpal is now in a different location than where it needs to be at. And when that happens over time, this joint then gets stretched out, and instead of being more or less straight here, this bone over here starts bending more backwards in what we call a hyperextension maneuver. And when that happens, there's a tendon over here. Because this joint is stretched all the way back, this tendon becomes very taut and ultimately ended up bending this joint here forward, so you get that Z deformity. And we also get radiograph or X-rays in clinic to help confirm our clinical suspicion and also to get an idea of, is this arthritis, and if so, how bad is it? So in clinic, we get either hand X-rays or dedicated thumb X-rays, and there are a number of findings that we try to identify. So if you look over here, this is a sample of a patient who has basilar thumb arthritis, particularly over this joint. If you look at this joint over here, you can see how there's kind of a gap between the end of one bone and the start of the other bone. or over here, or over here. But then once you look at it here, there's more density, hence more whiteness in that bone, and it's more difficult to actually find the joint space between the two bones. And this is by definition arthritis. Several terminologies used to describe it. There's narrowing of one or more joints in the basilar thumb region. So it can be here, which is the most common, but it can also be over here and here as well. There's the presence of bone spurs, also called osteophytes, and also increased density of bone that's located underneath the cartilage layer called subchondral sclerosis. This is all just saying that there's more whiteness in this area right underneath the cartilage layer. The reason that happens is because over time with arthritis, because the cartilage thins out, there's now more pressure on the bone because the cartilage is not absorbing the load appropriately. And when that happens, the body tries to compensate for the increased pressure by developing more bone around that cartilage layer. So you get the bone spurs, and then you get more density or more thickening of the bone underneath it as a way to try to compensate for the increased pressure that the bone is now experiencing. You also get migration, also known as subluxation of the long bone, which is a metacarpal, with respect to a trapezium. And if you have enough osteophytes or the bone spurs, sometimes they can actually free up and become a loose body, as you can see here. Yeah. And you can also get cysts within the bone in some cases. So how helpful are the x-rays? One of the studies showed that about 21% of the adults greater than 40 years old have radiographic evidence of arthritis in that region. So this was done in a study where patients come to the hand clinic, they get hand x-rays for a problem not related to pain at the base of the thumb, and then incidentally find that, well, about 20% of them, there's some evidence of arthritis in that region. So it's a pretty common condition. But overall, though, the amount of arthritis and the severity of the pain it's not always a clear-cut scenario. So all because one patient has more arthritis on x-rays doesn't necessarily mean that he or she has more pain. So clinical correlation becomes paramount in this situation. We combine the information we get from the x-rays, but more importantly, after talking to the patient and examining the patient. There is a radiographic staging system that exists to help quantify the severity of the arthritis. And a lot of the times it doesn't alter how we manage the condition, but if a patient commits to go in surgery for it, it might be helpful for preoperative planning for the surgeon. So there are four pictures up here, and they go from left to right. There's increasing arthritis. Over here, this is a metacarpal. Here's a trapezium. This is a good-looking joint. There's an even amount of joint space if you compare this joint to the joint around it. And essentially, there's no evidence of arthritic changes on the x-rays. If I move one over, right over here, there's slight thinning of the joint, and there's increased whiteness of the joint, but there's not a lot of bone spurs or a lot of deformity in that area. So this is the one on the left is stage 1, this is stage 2, and when it gets to stage 3, there's more narrowing of the joint. The bone spurs over here are bigger in size, defined as more than 2 millimeters. And then if we go to stage 4, there's more deformity in that area. And not only is this joint affected, but also the joint underneath it, called the scaphotrapezial trapezoid joint, that joint also becomes affected, and this is stage 4. Now to the most important part, how do we manage it? We start with conservative treatment, meaning non-surgical. This is always the first line, and there are multiple ways of trying to manage it. And if that fails, then surgical treatment may be indicated if the pain is bad enough. So starting with conservative treatment, modifying your activity plays a big role, and that includes using a jar lid opener, having a doorknob with a lever, or even trying to use writing utensils that have rubberized grip. The reason for that is because if you take a narrow pencil or a pen, then there's not as much surface area, so there's more contact, there's more pressure per area. But if you take a fat pencil or a pen that has a rubberized grip on it, that helps redistribute the force over a greater surface area. And patients may have some relief in trying that if they have problem with writing and such. Occupational or hand therapy also plays a role. There's a set of exercises called thenar strengthening. Thenar area just means the muscles around the base of the thumb, so this portion of it. And there are a number of exercises that the patient can do, and by strengthening that area, it can help try to take the stress off the actual joint, which is where the arthritis is at. Splint wear is another treatment option, and this is what we call a hand-based thumb brace. So, for example, picture on the right, this is hand-based because it doesn't go up way into a forearm, so you can actually maintain the motion of your wrist as you're wearing it. But it basically just isolates the base of the thumb so that you don't have as much motion in the area. Because the problem is along the base of the thumb, it's not in the forearm, it's not along the tip of the thumb. And you can get a thermoplastic, which is a custom made brace, such as the one depicted here. And our hand therapist will help you out with that if that becomes an issue. Or you can get it off the shelf, which is a neoprene brace, which is cheaper, but then it also tends to be a little bit more bulky. And it doesn't confine to the anatomy nearly as well, just because it's not custom made. But it's always worth a try. And typically, if I see a patient who comes to my clinic with this condition, I will refer the patient to our hand therapist so that he or she can go over these modalities in greater detail. And between these three modalities, I expect the patient to find some improvement in the pain level. It doesn't necessarily take it away, but hopefully it makes it more manageable. Other modalities or analgesics, just meaning that non-narcotic over-the-counter pain medications. You can also try topical analgesics such as Voltaren gel. This is a non-steroidal anti-inflammatory medication that you can actually apply directly over the affected area. So instead of getting absorbed by the bloodstream, most of it stays where you actually apply the gel at. So it works locally as opposed to systemically. Steroid injections is also a treatment option. The results are variable, but it may provide temporary, meaning about 2 or 3 months worth of pain relief. And it may also depend on the arthritis, because if there's advanced arthritis, then there's not a lot of space in that joint to actually administer the injection. And sometimes there's just bone on bone, grinding on bone. The injection might not be helpful. And the other thing I noticed is that the efficacy of the injection tend to decrease with subsequent injections. So typically, the first injection is the best injection. A patient might get maybe 3 or 4 months worth of relief, and then come back to clinic several months later, get a second injection, but it might only be helpful for about 2 months this time. This is a pretty common pattern with steroid injections, not just in the thumb, but included in the thumb. So, there's also viscosupplement injections, which is a couple of brand names include Synvis and Euflexa, and this is basically used to help lubricate the joint, and it's been FDA approved to use in the knee. So a lot of the patients with knee arthritis have received these injections before, but it hasn't been FDA approved to use in the hand. But there have been a couple studies that compare steroid injections to the viscosupplement injections, and overall there's similar efficacy between the two types of injections. What about surgical treatment? Well, indication for surgery, primary indication is just severe pain in setting of failed conservative treatment measure. So you've tried the splint, you've tried modifying the activity, therapy, plus or minus injection, and it's just not helping. Okay. The secondary indication is if there's such a bad deformity in the thumb to the point where it starts to affect the hand function. So the pain might be moderate, it's not intolerable, but the deformity is so big, so bad that it's hard to actually be able to open the thumb and use the thumb. That's another indication for doing the operation. But in most cases, though, delaying surgery does not eliminate the option for surgery in the future, meaning that you're not burning any bridges by waiting. You say that, wow, the X-rays look pretty bad. There's a lot of arthritis on it, but I'm not hurting that bad. Then in that case, man, you probably don't need surgery, because the pain has to be bad enough to the point where it justifies the risk of the operation and the recovery from your standpoint. So surgical treatment options. In general, the term basilar thumb arthroplasty is used to encompass the different types of surgery that are aimed towards treating the arthritis. And there are many treatment options, but I'm going to divide them to 2 broad categories. One category includes no implant, so not a total joint replacement surgery. There's no prosthesis in the joint. And then the other category includes the implant. So starting with the non-implant category, there are a lot of surgical techniques that exist, but the one thing all these techniques have in common is either partial or complete removal of the trapezium. So on the x-rays after the surgery, this will be a blank. You'll see a void. And it's not very intuitive initially because we're used to thinking, well, if I have knee arthritis, I'm going to get knee replacement surgery. The bone or the cartilage that will stand out is now going to be replaced with a metal implant. If I have hip arthritis, I'm going to get a hip replacement surgery. Well, in basilar thumb arthritis, studies have shown that the non-implant surgery, non-implant containing surgeries actually tend to do better over time. And I'll go over more detail in just a little bit. So studies reveal similar outcome despite surgical technique, meaning that a lot of the techniques involve removing this bone plus or minus an additional procedure as an adjunct to minimize the risk of complications down the road. So for example, there's what we call simple trapeziectomy, which just means that we remove the trapezium that used to be here and it's no longer here. So remove the bone and be finished with it, put it in the splint, and then that's it for the entire operation. A little bit more than that is doing trapeziectomy, meaning removing the bone, and a term called hematoma distraction arthroplasty. This is just a fancy way of saying that we now remove the bone, but then we also put a metal pin temporarily, either from this bone into the index metacarpal bone, or from this bone into one of the carpal bones. And the idea behind that is that if the bone over here has been removed, then theoretically, this metacarpal bone can subside, meaning it can migrate towards these little carpal bones. And you can get to a point where this bone is now touching on this bone because there's nothing holding against it. Well, with the pinning, what it does is that it basically puts the bone in a more anatomic position. So it prevents the bone from coming down and touching the scaphoid bone, which is over here. In the process, the body does a lot of the healing by creating more scar tissue in this area, so that when the pin gets removed, either a month or 6 weeks out from the operation, there's going to be enough scar tissue in this area that this bone is not going to completely collapse and subside. There's another procedure called trapeziectomy plus ligamentous reconstruction tendon interposition, or LRTI. This is actually the most common method of doing this operation. So this is an intraoperative photo of a patient that's about to get the surgery, and there are a few landmarks that are being marked. There's a curvilinear mark over here with the dashes. This is the proposed incision for the operation. And then these parallel lines over here along the forearm and wrist area, it says FCR. That's actually a flexor carpi radialis. This is a tendon that's along the wrist, and it attaches in one of the bones in the hand. So with the trapeziectomy and LRTI, that involves removing the bone, so that trapezium that used to be there now has been removed. And the surgeon actually makes a separate centimeter incision higher up to harvest about half the tendon, half the FCR tendon over here. So half of it stays intact, the other half of it gets harvested, and then the surgeon makes a drill hole into the bone here to create a bone tunnel, and basically take that half of the tendon that's been harvested and loop it through the drill hole so that you now have this. And in theory, what we're trying to do is trying to reconstruct the ligament, because I mentioned earlier that a lot of the ligaments get degenerated over time and they tear. Well, this is just in one way of supplementing the trapeziectomy by trying to anchor the bone where it needs to be at so that it doesn't collapse. Now, in addition, so I took half of the tendon, and there's some leftover tendon remaining, and you can actually just fold it back and forth and then put it in that place where the bone used to be at to fill the void. And that's what this procedure consists of. On this diagram over here, it shows that there's actually a metal wire over here, but a lot of the times that's not even needed in this case, because now you remove the bone, but you did some kind of additional soft tissue procedure to prevent that bone from collapsing down. Another treatment is called trapeziectomy and suture button suspensionplasty. And what this consists of is you remove the bone, but instead of working with tendons and making drill holes, you actually take this suture button and make a hole from the base of the thumb metacarpal here to the adjacent finger. So this is the index finger metacarpal. And then while keeping the thumb in the place that you want to be at, you basically put this suture button here, and then you anchor it and tighten it. So that way, this prevents the bone from kind of collapsing and subsiding. So on x-rays, it will look something like this. So you're not working with additional tendons, but you are doing something else besides removing the bone in order to prevent the thumb metacarpal bone from collapsing. Another procedure is called trapeziectomy and tendon transfer. So this is the same picture that I showed a few slides ago. This is the proposed incision site. You got this flexor carpi radialis tendon. And these are a couple schematics over here. So this procedure actually consists of taking a tendon on the side of the wrist, and this is called the abductor pollicis longus tendon. So it's actually, it attaches towards the base of the thumb metacarpal. So free it up and actually bring it over towards the flexor carpi radialis tendon over here, which correlates to this tendon over here. Just bring it over and then suture the tendon side to side. And by doing that, you're in theory creating like a little trampoline effect, again, in order to prevent the bone from collapsing. So those are all the non-implant or non-prosthesis containing surgery. Just really quickly about the implant-containing arthroplasty. So examples of that include resurfacing implant, meaning that we remove just a portion of that trapezium, but not all of it, and putting some kind of metal device in there to act as essentially a fake joint. Or you can get a total joint replacement, meaning that you work on both sides of the joint. The trapezium has a ball that goes into it, and then the metacarpal, which is longer, has a stem that goes into it, and you have essentially a ball and socket joint like you would in a total hip replacement surgery. Overall, though, multiple studies have shown that complications rates such as implant loosening are higher in total joint replacement surgeries. And as a result, the total joint replacement surgery in the basal thumb region has largely fallen out of favor in the United States. That's not to say that they're currently in the process of trying to come up with better prostheses, but it takes years for them to do a study to show that long-term wise, they have equivalent outcomes. Some of the issues to consider is what I call metacarpal joint hyperextension. I mentioned that earlier, where you get that Z deformity, which results in the knuckle joint being bent backwards at this level. So depending on the severity of that, if it's mild, meaning that there's about 0 to 20 degrees of hyperextension, then you can either observe it, just leave it alone because it's not a bad deformity, or you can temporarily pin it into a more anatomic position and let the body heal on its own and leave it in that position and remove the pin about a month or 6 weeks later. If it's moderate, defined as that deformity being about 20 to 40 degrees being bent backwards, then there are multiple soft tissue procedures that you can do to try to correct that deformity and put it in a more anatomic position. And if it's severe, meaning that this is bent way backwards, that just doing the soft tissue procedure, meaning working with the tendons or the joint around it, is not enough to correct the deformity, then the treatment for that is actually thumb fusion of that joint. So I'm purposely taking the two joints over here, take away all the cartilage, put the joint in a more favorable position so that you can optimize the function of the hand, and then putting implants in there to fuse the joint. So basically trying to make two bones become one and stay rigid. Additional things to consider for patients with mild arthritis, meaning either stage 1, where the x-rays are completely normal, but symptomatically the patient has pain in the area and there may be some instability in the area, or early stage 2, where there are some changes consistent with arthritis, but it's not severe in terms of on the scale of things. So one option is doing an arthroscopic debridement, meaning that I take make a couple small incisions and then put a camera in there, and also take a shaver in the area, and just to try to debride off some of the cartilage and trying to stimulate some healing in the area. Other treatment is called volar ligament reconstruction, and those are indicated for patients with minimal to no arthritis, but there's instability. So any kind of increased motion in the area causes a lot of pain. So even though the X-rays aren't bad enough to warrant removing the bone in its entirety, because of the instability, patient may benefit from having that ligament reconstructed as well. And the other option is doing a thumb metacarpal osteotomy. So this picture over here just shows that you've got the thumb metacarpal, make a little wedge over here, and then remove that wedge of bone, realign the bone, and then secure that area with placing screws. And by doing that, you're essentially trying to redirect the location of where a lot of the forces go, so that it goes from the area where it sees the most amount of pressure to the area where it sees a little bit less pressure, and hopefully trying to make the pain more manageable. Okay. I will say that most of the time when patients present to clinic, the arthritis has gone bad enough to the point, either clinically or on X-rays, to the point where patients aren't candidate for these procedures. And the other thing is that if a patient has a higher grade arthritis or post-traumatic arthritis, meaning that this wasn't just because of wear and tear and because of age, but patient had some kind of injury where he or she broke a bone in this area, and then the bone went up to heal nicely, but now there's more arthritis in that area because the cartilage got damaged from the time of injury. So in these situations, especially in patients that are younger, less than 40 years old, or that are manual labor, one option to consider is trapezial metacarpal fusion, meaning that instead of removing that bone and doing soft tissue procedure, I'm basically going to make this joint, combine the two bones, and make it be just one rigid joint. The benefit of that is that it eliminates the risk of instability, because now you have a solid block of bone, and hopefully improve pain because the arthritis is no longer there. The drawback is that there's about a 7 to 10% chance of pseudoarthrosis, meaning that we try to fuse the bone together, but at the fusion site, the bones aren't fusing. So you get what we call a non-union. So what about recovery? So this recovery is going to be pertaining to the most common type of procedures, where I remove the trapezium and then plus or minus additional procedure. So on the day of surgery, it's outpatient surgery, meaning you go home on the same day. Types of anesthesia can either be general anesthesia or regional anesthesia, where the patient has the arm numbed up, but he or she is not necessarily completely asleep and doesn't get intubated. Okay. And patient gets discharged home, and it's short arm thumb spica splint. As depicted here, it goes from the forearm, goes past the wrist joint and into the thumb. So this is a bigger splint than what I would recommend for patients that are just trying to control the pain with conservative measure. And not a lot of weight bearing. You can move the index to pinky fingers, but minimal motion at the thumb just to let it heal. What about the rehab process? So no studies have specifically examined the effect of different rehab protocols on the outcome of surgery. And there was one review that tried to compare the different types of rehab protocols, but there wasn't enough evidence to make a formal recommendation on what type of rehab course is ideal. However, most surgeons will recommend 4 to 6 weeks of immobilization, either in a splint or a cast after the surgery, followed by gradual range of motion exercises, followed by strengthening exercises. So for a post-operative course, on the day of surgery, patient gets discharged home in the thumb spica splint. This is one of the more commonly used rehab protocols, and I use it myself as well. Post-op visit, so about 2 weeks after the operation, patient comes back to clinic, get the splint taken down, the sutures get removed, and then be immobilized in a thumb spica cast. So this is essentially the same size as a splint that a patient had on when he or she went home, except that this is now circumferential, so it's more rigid. Okay. And then come back to clinic about 2 weeks later. So about 4 weeks after the operation, the cast gets removed in clinic. And I actually like for my patient to see a hand therapist so that he or she can start working on range of motion protocol. That will be ongoing for the next month. And also to receive a thermoplastic thumb spica splint, something that looks like that. So this is something that's removable Patient can wear it when he or she goes out to the public, but then can take it off during the rehab, during the range of motion exercises, and can also take it off for shower and hygiene care. And then come back about a month later. So about 8 weeks after the operation, this is when we start strengthening protocol, start working on more strengthening now. And in the process, also continue working on range of motion exercises and eventually come off the splint. And then about 12 weeks after the operation, so about 3 months after the surgery, we gradually return to unrestricted activities and we discontinue with formal hand therapy. And from that point on, the recovery is going to be more tailored towards just being able to do the things that you would be able to do before the surgery, but with hopefully less pain. So despite being able to resume quote-unquote normal activities at 3 months, meaning from a surgeon standpoint, there are no formal restrictions, it may take the patient about 6 months to a year to achieve maximum benefit from the operation. So it does take a while to plateau from the recovery. So let's look at some outcomes. So trapeziectomy, meaning removing that bone, plus or minus the adjunct procedure, significantly improves pain in about 80% of the patients and also preserves functional range of motion. So in other words, about 80% of the patients are happy that they did the operation. They're like, the pain is a lot better, if not completely gone. Yeah. Most of the remaining 20% report no substantial improvement in pain, but a few experience increased pain and stiffness. So of that, so about 80% of them do well. Another 10%, they get better, but not to the point of where they're pain-free or not as much as they were expecting before the operation. So I'm about 50% better, but it's not 100% better. It's not 90% better. And then the other 10% virtually find no substantial increase in pain or improvement in pain. The other thing is looking at strength. So thumb strength, such as pinch strength, remains actually weaker than a quote-unquote normal thumb. It's to about 75% of the strength of the unaffected side. Now, despite this though, a lot of the patients feel that he or she is stronger after the operation because they're able to do more. They have a more functional hand and there's less pain. So even though if I were to measure the actual amount of strength, pinch strength that patients have, they feel like they're actually stronger because that pain that used to bother them and limit them is not there anymore. Every surgery, there's a chance of complications happening. Early complications, infection rate is about 1%, which is pretty standard for a lot of the operations. Patients do get antibiotics through the IV before the operation. Chance of delayed healing at the incision site, that really depends more on the risk factors that patients have prior to the operation. Hematoma just means getting more bleeding anticipated in the area to the point where there's blood that accumulates underneath the incision site, and that may be a cause for pain as well. Numbness and tingling along the superficial radial nerve branches. This is a nerve that supplies sensation to the backside of the thumb and the index finger. And one study showed that there's about a 1/3 prevalence at 3 months after the operation to have some numbness and tingling in the area. But several years out from surgery, less than 10% has this complaint. And this is also approach dependent, meaning that there are multiple ways to make the skin do that surgical incision. And this number is strictly related to one of the ways of doing it. And complex regional pain syndrome risk is about 2%. This is a condition where for reasons that are not exactly certain, patients develop increasing severe pain that's out of proportion to what it should be at the post-operative mark. And that risk is about 2%. And there's not really a way of predicting who will get that, who doesn't get it. Late complications, most common is continued pain, about 10% of potential causes. There are several factors. One of them is incomplete removal of the trapezium, meaning that instead of removing the bone in its entirety, let's just say if I only remove half of it, then theoretically the gap between the two bones is now not as much as if I were to remove the entire bone. So it doesn't take as much migration of this metacarpal before it starts hitting the bone below it. The metacarpal subsidence, meaning that this metacarpal, the thumb bone, keeps on migrating to the point where it touches the scaphoid bone over here, metacarpal bone. The other potential factor is the failure to address scaphoid trapezoid arthritis. It just means that now that I got the a trapeziectomy to remove this bone, patient no longer has arthritis in this area. But if patient had pre-existing arthritis over here, then by definition, this hasn't been treated, even with the operation. And there are other things that surgeons look for in order to make sure that this doesn't happen. However, oftentimes in this patient group, the exact cause of the pain is uncertain, meaning that I can get X-rays after the operation, everything looks appropriate, the bone's where it needs to be at, there's not a lot of subsidence, there's no impingement, and there's just not a clear reason for why the patient is still having continued pain. Overall, though, there's no long-term difference between simple trapeziectomy, meaning just removing that bone and nothing else, and doing more complex procedures in terms of instability of the thumb as it relates to function and grip strength, and also pain. Overall, though, long-term revision rates with trapeziectomy plus or minus adjunct procedure, this is in the non-prosthesis group, it's about 3%. So vast majority of patients who get the operation gets one operation and they're finished. So in conclusion, basal thumb arthritis is a common condition. The diagnosis is clinical, supplemented by X-rays, and treatment consists of primarily non-operative modalities, but then every now and then operative modalities. Primary indication for surgery is continued pain, despite having tried all the conservative treatment measures, and most of the time there's no harm in delaying surgical treatment. The mainstay of procedure is removing the trapezium, plus or minus additional adjunct procedure. And in most cases, that reliably relieves the pain with a relatively low complication rate. All right, well, thank you. I appreciate it. Thank you.